welcome back. Welcome back. I hope you are enjoying this implementation track. I'm having a great time listening to all these excellent speakers dropping words of wisdom. And next, we're going to have Dr. Patricia Fulmer, who's coming all the way from Alabama, warm and sunny Alabama, who's going to talk to us today about the role of artificial intelligence and virtual reality in the management of glaucoma, which I'm very excited to hear about. And so here we have it. Dr. Fulmer, take it away.
Great, thank you so much. First of all, before I get started, I just want to say thank you to Eyes On Glaucoma for having me. And I know this event is very detailed to put on, but they always do such a great job. So I'm really, really thrilled to be a part of it this year. We are going to talk about artificial intelligence, virtual reality, where that plays in glaucoma these days. You know, our world is ever evolving, technology is ever evolving. So I'm excited to dive into that with you guys this afternoon, depending on where you are. As we said, I'm Dr. Patricia Fulmer. I'm out of Huntsville, Alabama. I graduated from UAB in 2012, so coming up on 10 years, I guess right at 10 years, which makes me feel very old. I was a resident in ocular disease and primary care at the VA in Amarillo, Texas. So was blessed to see quite a few patients out there and learn a lot, which I feel like, prepared me for the next step. And then I ran a center that was a medical referral kind of disease only practice here in Huntsville for about 4 years. We had some surgery within the facility and different things like that, and then kind of missed private practice. I jumped back in 2017 into a group practice here in town, and eventually followed my passion to have my own. So here we are, open cold, the end of 2020 in the middle of the pandemic, which is a great time to open a practice, but it's been a fun ride. So all these different, modalities of practice has given me a really great opportunity to see a lot of glaucoma and see a lot of disease. And I'm just always looking for what we can do next. So, so this topic certainly kind of speaks to me and hopefully to you as well. Quick financial disclosures, nothing too important for this lecture, but Allergan, Zeiss, and Cynosure, and just because it's more fun to look at animals than financial disclosures, those are our two little fur babies. So before we get into the AI and virtual reality portion, I kind of want to just do a little background because I think it's important to appreciate not only where we're going, but where we came from. Glaucoma was derived initially from the ancient Greeks. So it actually has been around in concept of some sort since about 400 BC, when Hippocrates first started writing about a blinding condition that he termed glaucos or glycosis. It was a shining or kind of a gleaming of the eye. It was sea-colored green, which we now know is more of a cataract process. But basically, they put that term on any kind of blinding disease that occurred in mostly the elderly patients. It was really indistinguishable at that point in time, of course, between cataracts or inflammatory problems, really before the 17th century. And we started to figure out that there was an association between IOP and glaucoma in 1622. So a lot longer than I thought, but 400 years ago, we actually made that connection. So that's pretty incredible. In the mid-1800s, Donders actually discovered that elevated IOP caused blindness. So he confirmed that, and we had a few different players really figuring out the whys behind that. Von Graff and Jaeger thought that it was elevated aqueous fluid that led to the damage. Lieber had to do with the ciliary body, finding out that that was the source of aqueous humor secretion and that maybe a malfunction there. And then Von Graff introduced the iridectomy actually in 1850s. That's a long time ago for a procedure like that, in my opinion. So it's kind of, really eye-opening when we look and see how far we've come, but also really how much hasn't changed in 200 years. So the understanding of those fluid dynamics were first published in scientific articles in 1905, and of course that's really where our focus has been ever since. In 1876, Lecoeur introduced the anticholinergics. We started to get that from different places, first sabine, then pilocarpine. We figured out that pupillary meiosis was helping drain that fluid and improve this condition. We then moved on to corneal punctures as early as 1848. And then, like I said, we had the iridectomy in 1856. Goniotomy started 1892, but we didn't really start doing that in a popular way until 1936. So moving our way along. So this is just a quick look at sort of where the background of those drugs have come from. It's been, again, about 150-year process for us to figure out different drops, and really the ones that we use today, of course, didn't come around until closer to the 80s. And then we went for about 20 years between the prostaglandins and our newest category with the rhokinase inhibitors. So looking at glaucoma by the numbers, we have over 3 million Americans that have glaucoma, but only about half of those know. So of course, that's why we as eye care practitioners are always trying to get people in the door, try to get them to have those annual eye exams so that we can diagnose and treat and hopefully prevent the blindness that can come with this condition. Over 120,000 Americans are blind from glaucoma, which accounts for about 9 to 12% of blindness cases in the US. The sad part there is, so many of those are preventable if they had come to see us a little bit earlier. So education is, of course, always key. The World Health Organization states that glaucoma is the second leading cause of blindness worldwide. So again, it affects us all. It affects the world. It affects our country. It affects us day to day in our practice. So figuring out where we're going with this is truly important. It is the second leading cause of blindness in African Americans behind cataracts, and it's 6 to 8 more times more common in African Americans than Caucasians. And they're also 15 times more likely to be visually impaired than Caucasians are. It's estimated that there's 60 million glaucoma suspect cases worldwide. And of course, they expect that number is probably lowballed for the simple fact we're not seeing everybody that we need to be seeing. But it does account for over 10 million physician visits per year. So that's quite a bit. 2 main categories of glaucoma, of course, primary and secondary. Our primary glaucomas are going to be our open angle glaucoma, our angle closure glaucoma, normal tension glaucoma, and congenital. Our secondary glaucomas are going to be more of our neovascular, pigmentary, exfoliation, and uveitic. Quick review on those. Open angle, of course, is the most common type with 9 to 10 Americans with glaucoma. Angle closure is more emergent. Of course, the patient's going to present with pain, redness, nausea, blurry vision, and that is something we want to treat immediately. Normal tension glaucoma becomes a little more tricky. We know that progression is more likely. We want to keep those people under close watch because they are at risk of progression. They're a little harder to treat. Higher risk of that in people of Japanese ancestry, also those with family history of normal tension glaucoma, irregular heartbeat, or low blood pressure. And finally, congenital glaucoma, which of course is rare, but not rare if it's in your chair. So 1 in 10,000 American babies. They tend to present with larger eyes than normal, a cloudy appearance of their cornea, very photophobic, increased hearing. I know it can be hard to get pressures on babies, but it's doable. So if you have a case that you suspect, certainly try to get that reading or get them to somebody that can. Secondary glaucomas are a little trickier. Of course, they come from something else. It's not just a process with the drainage, but it's a process with drainage problems due to something. Neovascular glaucoma is typically in our diabetics and our hypertensives. Pigmentary glaucoma is going to be more of our iris pigment that's blocking aqueous drainage. So we're thinking of illumination defects, young myopic white men typically. Symptoms can include blurry vision or rainbow kind of halos, especially when they exercise. So it's something to keep in mind. Exfoliation or pseudoexfoliation glaucoma, we don't see the debris that clogs up the trabecular meshwork or is thought to clog up the trabecular meshwork, but we do see that debris land on the lens. So anytime we see that presentation with our lens, we want to keep that in mind. Higher risk, of course, with family history and a faster rate of progression and higher IOPs. Uveitic glaucoma, actually 20% of people with uveitis develop glaucoma over time. Really don't know the exact mechanism. There's a thought that maybe we get scar tissue or inflammation in the angle that blocks drainage, but we want to watch for that in any of our, especially chronic uveitic patients or recurrent. And of course, there's other things like trauma, cataracts, tumors, etc. So glaucoma is a big puzzle, right? We have to put all the pieces together to know what's happening with our patients and where to go and how to treat. We look at history, fundoscopy, fundus imaging, pachymetry, gonio, corneal hysteresis in some practices, tonometry, OCT, visual fields, and AI. So the last two are definitely where we're going to spend the majority of our time this morning. Glaucoma is, as I said, always changing. Technology is always changing. That could be said in anything in the world, but especially in medicine. Before we dive into visual field and AI, though, I just want to give you a little quick update on a couple things happening in OCT and tonometry. So OCT, biggest thing there is OCT-A. We've had it out for a few years now, but it allows for angiography to be performed alongside traditional OCT. So we're able to better intercept things, better to predict them and interpret what's going on with our patients and get ahead of that, which of course is our ultimate goal. Tonometry is being moved to more of a home-based thought process because we know that we need to see what's happening with that pressure more than once every 3 months or 6 months or whenever you may be seeing your patient back. So there's a big push for at-home testing. We've got the iCare Home and Triggerfish as the two main ones. iCare Home actually is the same rebound tonometer that we're familiar with in practice, but it guides the patient through the process. There's no anesthesia. It can store up to 1,000 measurements and detects which eye is tested. So it's very user-friendly, very easy to do for the patients, and then guides that patient through audio instructions. So I have seen some colleagues that are kind of running these out to patients so that they can get a serial tonometry kind of reading or at least a day-to-day idea of what's happening with their pressures. It's great for people that are maybe progressing and we aren't quite sure why. Maybe your clinical data isn't showing anything, but they're progressing anyway. So that's one way to do it. Triggerfish is a little more in depth. That's going to be a contact lens that actually works with an antenna that's adhered to the periocular area and then transmits the data to a recorder that the patient wears. It can be done in any position and actually measures every 5 minutes for 30 seconds. So we get quite a lot of data from that. Can be worn while the patient's asleep. It doesn't matter if they're laying down, standing up, they can wear that all day long. So again, some practices are sending these home, but it is still a fairly new technology. We're not seeing a ton of use of that quite yet. But I do think some of these home technologies are going to become more commonplace for us. All right, so let's dive into visual field testing, everybody's favorite test. I'm sure none of your patients complain when they have to come do their visual fields. I know mine love it. But virtual reality is kind of bringing a different take on that. So there's two different areas that visual fields have really progressed in. One, our testing, and two, our method. Our testing for a very long time has stayed our 30-2 or 24-2. Of course, most clinicians have moved toward the 24-2 plans, unless a patient maybe has just had years and years and years of a 30. But do you know how or where perimetry even came from? I didn't. I know that most of us think of it as, a test that's been pretty much the same for quite a while, and we're not wrong there. But it actually was first described again by Hippocrates in the late 5th century of BC. Ptolemy tried to quantify the visual field and recognized that it was at least a somewhat circular field in 150 BC. And the first illustration of the visual field was in 1602 by Ulmus. So again, over 400 years ago, which is incredible. The blind spot started being mapped in 1668, and we began describing degrees of visual field in the 1800s. We actually started getting our first quantitative measures of that in 1856, again by von Graf, obviously a very big contributor to eye care and our profession over time. The tangent screen was our first method of truly measuring that, and the first thing that we recognize today is something that we still do in practice in some cases. It was developed by Yannick Urim, and then Goldman perimetry finally came around in 1945. Goldman really hasn't changed a ton since then and has been, held as the gold standard in pressure measurements and then also in testing. So we still see Goldman in visual field as the main precipitous of what we see now as our automated visual testing. So in the 60s and 70s, we started to have automated visual field testing. We had the first automated perimetry, which was the octopus, and then that became the Humphrey field analyzer. So again, working on that technology from Goldman in 1945, and of course his other roles with pressures and everything like that. Now we've actually moved on to adding a different layer to our 24-2 test. So a lot of the newer visual field machines that you're going to see, and maybe even have seen already, are going to have another test called the 24-2. Traditionally it was 24-2 and the 30-2, but now we have the 24-2C. Dr. Hood discovered that in many glaucoma patients, there was a defect in their macular area, regardless of the stage of glaucoma, and even in some glaucoma suspects. And so with those, we were missing with the 24-2 and 30-2, we were missing a lot of those defects. We have found that actually in 15% of what we consider normal 24-2 tests actually had damage on the 10-2 visual field, which a lot of practitioners don't necessarily run on their early glaucomas or their glaucoma suspects. So they developed the 24-2 test, which added points within the macular area to capture more of those potential loss areas of our vision. So you can see in the image, the gray dots, the large gray dots, are going to be your traditional 24-2. The smaller dots are our 10-2, and then the blue dots are the 24-2C extra testing areas. So you can see we have a much more concentrated test within the macula. So where does visual field testing and virtual reality come together? Virtual reality testing has actually progressed quite a bit in just the last few years. And again, important to kind of see where we came from virtual reality in general. It's increased, tenfold with the increase of tablets and phones and virtual reality headsets. The first virtual reality that's known in the world really was the Sensorama in 1956, which was one of the first virtual reality systems ever invented. The first head-mounted VR system, which is kind of what we think of today, came around in 1968, and we started to see that move toward using it in science and other applications. So NASA and the military actually adopted virtual reality in the 80s and the 90s for training and simulations, and they still do use a lot of virtual reality and simulations today. It was mass produced starting in the 1990s for arcades, so some of you may remember virtual reality arcades back in the day. But we started to see the first PC-linked virtual reality in 2010, so not that long ago. Between 2014 and 2017, there were multiple evolutions of that led to untethered VR in 2018. So now that we're able to walk away from the computer, we can move, we can do it in whatever room, whatever setting we need to. Their applications have really just blown through the roof. So we've started to introduce computerized or virtual reality or augmented visual field testing before these headset types that we actually see today. The Morse field motion displacement test was really the first one that had any kind of repeatable credence to it. It was laptop based. It was designed for speed and ease of use. Had white lines that would kind of wiggle on a black background. So the patient fixated and they would identify when they saw a wiggle within the lines. It was a 2-minute test. It's no longer available in that we've had other progressions and inventions since then that have kind of surpassed its technology. But it was a really great start. The Melbourne Rapid Field Test, on the other hand, is still available. It's actually an iPad app. It's free. It's moving fixation target that can extend the degrees of vision that's tested. So you can see here in the image, this is the Melbourne Rapid Field Test. So it tells the patient where to look and then where to touch when they see something. And then as it's testing, it'll move that central fixation from side to side so that as they're looking one way or the other, they're getting a much larger field of view that's being tested. It's a screening tool, so it's similar to a tangent perimeter. But it is easy to use, very portable, again, inexpensive. Like I said, the test itself is free. So if you have an iPad, that's really all you need. And it was tested against the Humphrey field analyzer with good repeatability. So it actually correlated quite well with the Humphrey, which a lot of us sometimes think that because we're used to doing Humphrey testing or something similar to that, that these portable and computerized tests maybe aren't as good, but you'll see a lot of research actually shows that they really are. It's very similar to the CETA-FAST in its speed of testing, so not really extending that much, which is good. So now we're starting to see our untethered headset visual field testing coming around with VR incorporated in it. There were a bunch of challenges that we needed to answer with visual field testing that every one of us that has had a patient that's done a test has seen. Maybe you've run a test yourself or your technicians have. We know there's complaints and challenges with traditional testing. And so virtual reality really sought to fix that and to try to address those problems. The first one that a lot of us think of is that it's very difficult to control fixation with portable devices. We had these iPads and things of that nature, but couldn't really control where people looked. And then in our traditionals, it also was very difficult to control fixation because people get bored. They kind of tune out. They aren't maybe adjusted correctly, or they're not comfortable. So you have to have trained staff there to really watch the eye and make sure that the patient is looking where they need to look. Virtual realities answered that. They had the headsets typically allow for adjustable fixation, and it has its own built-in gaze tracking on most of these systems. So this takes the user error out. It takes the need for staff to monitor out, which is fantastic. It is self-tracking, so like I said, no staff monitoring is needed. So you can put it on a patient, walk away, let them do the test, and your staff can be doing something maybe a little more productive than watching a fixation test. And it does have gyroscopes within it so that it can interpret the head position. So it doesn't really matter how maybe the patient has a neck injury, they can't move their neck, or has a head tilt. That's okay. They can use that in the same way, and the visual field test or module itself can adjust accordingly to know where that head position was and how to track it. Another challenge is that it's very traditional perimetry. It's very, very difficult for patients with mobility issues. Again, head or neck problems. I know I get a lot of complaints from my patients about the comfort of the test. It's hard to keep their attention. And sometimes patients really struggle with having one eye occluded. They don't like it. It kind of freaks them out a little bit, or maybe they just have a really hard time, seeing and not suppressing the other eye. Again, that's been answered. Our virtual reality tests have our gyroscopes, so head position doesn't matter. Plus, the patient can be tested in any chair or any position. So you can take this to nursing homes. Wheelchair-bound patients have a very easy time doing things. You can do it in your exam room or your waiting room. I have a lot of colleagues that are starting to use it in the waiting room, not tying up an exam room or a testing room at all. It's very immersive in that the patient is in it. If you've ever done virtual reality gaming or anything like that, you're in the game. And it's the same way with these tests. So as the patient is doing the visual field, it's coaching them. They're not seeing what's around them. So they're kind of, zoned in. A lot less chance of them trying to get bored or look around. And it is actually able to test each eye without occluding. So the virtual reality headsets are monocular testing, but with a binocular feel. So both eyes are open. They're not trying to have to, put a patch underneath a virtual reality headset. Some traditional perimeters don't offer every test that we need. So, some of the basic models maybe don't have a ptosis screener, or they don't have an esterman, or they don't have different levels of that, or maybe a 24-C that we were just talking about, 24-2C that we were just talking about. That can be answered pretty easily with virtual reality. So a lot of these field companies have come out with virtual reality headsets that actually incorporate all of those tests. Your 24-2s, your 30-2s, your 10-2s, ptosis screeners, and sometimes in certain ones, even other tests like color, stereo, visual acuity, pediatric visual field testing, so all kinds of different myriad of tests. And the challenge here is that we need multiple tests to track glaucoma. We can't just do one visual field, call it a day, and move on. So virtual reality headsets can be performed anywhere. You could send this home with the patient to do once a month, or they could come rent it out, take it home and do it over the weekend. These modules and this method is being perfected, of course, as we learn more about virtual reality and these become a little more accessible. But I have seen situations where patients have been sent home with these and are being, able to do the test in the comfort of their living room. This allows us to get more data. And really, at the end of the day, when we see glaucoma patients, the more data that we can ingest and process, the better, and the more that we're going to get ahead of any kind of progression. So another benefit of virtual reality. Cost, of course, is always a factor. In our traditional perimetry, cost really can vary quite drastically, from anywhere in the teens to 30s, maybe 40,000s, depending on what kind of test you want and how in depth and how many different tests and all of those different features. Virtual reality, on the other hand, is typically much less expensive and more affordable than our traditional perimeters. And we'll talk a little bit more about that with a few examples. Some common questions that I have gotten about virtual reality visual field testing in the past is, can I bill for that? You absolutely can. These tests have been put up head to head against the Humphrey field analyzer and have been vetted to be the same quality testing that we're used to having. So you're still doing a 92083, you're still doing a 92082, depending on what kind of test you're doing. You can bill those out the exact same way. And depending on what company you go with, they can definitely break down what testing codes work for their particular machine. Are they compatible with Humphrey? As I said, yes, they absolutely are. Many companies have now done extensive research to prove that. Some have done, 4, 5, 6 studies just on theirs and have that data to show you. So yes, that's been confirmed quite well. So let's look at just a few examples of virtual reality headset visual fields that are out. There's more companies than this, but I wanted to give you just a sample here. First of all, the Visual by All Eyes. This one has gained a lot of traction. It's probably maybe the best known one that we have out. It has a full suite of visual field testing. So as you can see here, we can truly do just about every test that we're used to doing. It has a test time of 3 minutes for full threshold and about 45 seconds for screening. So you can do this on every patient if you want to do a screener, or you can do it more for your true disease patients with the full threshold. All Eyes offers 3 different models. There's an S unit, which is for office use. There's an ETS unit, which is also office, and then there's an H unit for home. The H is actually the only visual field device that's approved for home testing. And it has its own CPT code. So that was added in 2019. And of course, the company would be able to provide you with that. Other tests that are available on this unit include visual acuity testing, color vision, pediatric field testing, contrast sensitivity, low contrast, pupillometry, EOMs, eye tracking. So depending on which model you get, depends on which features you get. But the price point of the Visual is around $13,000. This one is performed with the patient's own correction, so you don't have to do loose lenses. It just goes right over their glasses or contacts. M&S has put out a new system recently that is doing quite well. It also has a full suite. It doesn't have quite as many as the Visual, but it comes close. A test time of less than 3 minutes per eye. It does take a little bit longer, but not entirely long. It's definitely still in the realm of our traditional perimetry. 45 seconds for screenings, and it does export easily to a tablet that they send with it, has eye tracking included on all models, and allows you to do stereo testing. Price of this one's a little bit lower, about $11,000. And again, patient's own correction. They are planning to add more testing as the years go by, so that'll be great to see. I've tried this one myself. It's pretty interesting to do. It coaches you right through it. It's hard to mess it up. Third one is Virtual Fields virtual reality headset. That's just the name of it. It's the name of the company and the name of the field. They have a few tests, a little bit less, your 24-2, your ptosis and your Esterman, but it is still a pretty complete unit. Gives a great progression analysis, threshold and screening tests like the others. They do claim faster times and lower false positives than some of their competitors, and offer color testing This one gives you a lease model. You can lease to buy, but the price for leasing is $199 a month or $21.48 for the year. This unit actually uses trial lenses within the headset, and so that can be downloaded to JPEG or PDF, and then multiple validation studies. So they've done quite a lot to make sure that they really show that their unit measures up against the Humphrey field. The trial lenses are a little more cumbersome than maybe the competitors, but they slip into the unit very easily, so it's not really anything that we're not used to doing. And then the Hero. This one has 3 different codes that you can use, so that indicates, it doesn't completely spell out on their website or their information exactly which tests that they do, so I didn't want to claim something that wasn't true, but it does say that you can bill all 3 of these CPT codes, which means that most likely they offer the same type of visual field suites that the others do. This one actually offers dark adaptation as well, color vision in the D15, testing, contrast sensitivity. It's a subscription model, and from a lot of distributors that I'm talking to and hearing from, it's very similar to the M&S or the All Eyes. This one actually came from the researchers at Bascom Palmer, so a lot of smart big names behind that one. So just to summarize, virtual reality is really the new frontier in visual field testing. I'm looking daily at putting it in my office. I know that a lot of glaucoma specialists and other practitioners are finding this to be a good answer to some of our challenges that we've had. It's very lightweight. It can be performed in any position or location. It can be performed in any lighting. There's no occlusion needed. We need the patients on glasses or contacts in many cases. We don't have to worry about trial lenses. It is billable, and sometimes you can get a ADA tax credit. So be sure to talk to your accountant if you do go get one. Some concerns there. Sometimes patient understanding. Our older patients maybe aren't as familiar with VR as our younger patients are, but they do a good job of coaching it through, so that's usually not too much of an issue. We're unable to view the eye, so if they aren't listening, if the fixation monitor goes down, anything like that, we really can't see where they're looking. But again, fixation is built into all these, so kind of a minimal risk there. Some patients may feel a little claustrophobic if they've never done a virtual reality headset because they are enclosed, but you can usually coach that through or pause the test if you need to. So let's switch gears into AI. It was first developed in 1950, which again, I don't know about you, but I didn't know that AI had been around for that long. So almost 75 years ago, we started seeing it in gaming. They would figure out that we could kind of program an if-then statement to, if the human did this, then the machine did that. It wasn't used really in medicine or anything like that, because at that point, human cognitive ability was really still better than AI. In 1980, machine learning was developed, so that gave us the ability to learn patterns in data without being explicitly programmed. So the computer actually starts to pick up on trends and learn things without the if-then statements telling it exactly what to think. This allowed, again, gaming was really the focus to begin with, but this allowed those games to be adapted to where the computer was really playing. The human would make a move, the computer would learn that and move accordingly, and so we started to see that computer sometimes even beating the humans. It really wasn't widely used in medicine either. Still, when the head-to-head comparisons, the clinicians typically won out on their ability to interpret and process the data. That all changed in 2010 when deep learning emerged. So computers have now, by research, surpassed us in a lot of ways when it comes to processing data. It really replaced machine learning. And what it did was it took the neural network that was part of machine learning and adapted that to function like our neurons with receptive fields. It actually is a layered neural network. So they modeled that after the visual cortex, which means that it speaks very well into eye care because our visual cortex, of course, is meant to do that. And so now artificial intelligence can be meant to do that as well. It's been successfully integrated with high data outputs. So basically, we've taken this deep learning, applied a ton of data to it, see what the output is, and it's been quite reliable there, particularly with images, which makes a lot of sense if it was modeled after the visual cortex, since that is what our visual cortex is meant to do. And now it's being used in really all areas of science. Some notable ones: predicting earthquake aftershocks, drug discoveries, predicting strokes, assessing cancer lesions or metastases. So lots of different applications. Of course, eye care is one of those that we'll talk about a little bit more in a moment. Let's look a little bit deeper, though, no pun intended, at deep learning. It was modeled after the visual cortex, as I said. So we're able to discern the edges, just like our eyes and our brain are able to discern edges. Deep learning uses a flashlight in a similar way that our human brain has orientation and position cells. So we're able to pick up on where an image starts, stops, where the different parts of the image is. And then it also uses a high degree of spatial invariance. And what that means is that the image can be shown at any angle, any orientation, upside down, doesn't matter, any lighting, and the computer is still able to process that picture. The layers are not all connected from neuron to neuron, and this holds true in both the visual cortex and in deep learning AI. So in our visual cortex, if we had every single neuron connected to every single neuron, it would be way too large to actually fit in our skull. Evolution has given us the ability to connect the right ones and run different matrix analysis that we can put everything together. And so they've mimicked that with deep learning to where they connect the neurons that need to be connected, and then those can talk to each other through a series of different connections versus having to have too much computation that it would take forever for any kind of process to happen. Condensation and summation occurs at the end of a deep learning algorithm, which is very similar to level V1 of the cerebral cortex. So when all that information gets to the back of our brain and reaches that visual part of the human brain, it's processed and put all together and summated so that we know what we're seeing, and that actually happens the same way in deep learning. The deep learning machines and cortical cortexes have feed forward and feedback arms, which basically means that it uses back propagation, which is a big word for saying it takes all the information that it has put out, it looks at it, it filters back through all the input to make sure that it's weighted correctly and that the data that it's producing and outputting makes sense with what the expected values for whatever problem it's trying to solve is. So basically it checks and balances. There's three stages of learning with deep learning AI. First, there's a training stage. So the machine is actually given a sample set, then it creates its model and its algorithm to fit to. After that's been created, it's validated. So a validation data set is introduced, and that establishes how well the model actually fits into the training data set. So does it work, basically? And if there's problems, then those are manually fixed and corrected. And then it's tested. So then an actual data set of something that they're trying to discern, an image or what have you, is introduced, and it determines how well the model actually works. So this is just a little schematic to kind of show you we've got AI as a very large category. Machine learning narrowed that down a little bit, and then deep learning took that even further to use a multi-layer neural network, very similar to the visual cortex. In optometry and ophthalmology, AI is really being used across the board. We're starting to see it in diabetic retinopathy, retinopathy of prematurity, AMD, and of course, today's topic, which is glaucoma. Within glaucoma, there's really kind of three main areas that we see being utilized and really finding a lot of benefit with AI. First, it's identifying at-risk patients. So as clinicians, our main goal every day when we see our patients is to identify what problems they may have, what may cause them vision loss in the future, and get ahead of it. AI can play a really big role in that it evaluates the images or the test to determine which patients are likely to develop glaucoma or maybe already have the condition. It's also used in interpreting data sets. We do our best to put all of these visual fields or OCTs or whatever tests you may be looking at together, but AI can actually interpret that data set over time with a lot more accuracy than clinicians can. It can utilize poor data. There's many times that visual fields come to mind here where maybe a patient wasn't so great that day. They were tired or dry or whatever caused an issue. And so the data that came out of that isn't as great. And maybe that makes me question, did they really progress or is this, just a trash coming out of the test because it was trash going into the test? They can use AI now to really extract that data and figure out what is true progression versus just noise, even though it's poor data. And one thing that I think is really interesting is we can actually customize the normative data. So our machines now, our traditional OCTs and perimetry, have a normative data set that is pulled typically from age, and that looks over the whole population. AI can start to say this patient's normative data based on their baseline testing is X, therefore they've progressed, or to even narrow it down to say this patient is a severe glaucoma patient, so we're only going to compare them to severe glaucoma patients. Gives a lot more precise interpretations, and that means more precise treatment options. Lastly, it can forecast disease outcomes. So we can kind of start to see, do we think that patient A is going to progress faster than patient B? What's their likelihood of blindness? And that allows us to get a more accurate goal for intraocular pressure. In fact, some AI systems can predict that IOP goal and tell you exactly where you need to set that target. Looking a little deeper into how those three goals are achieved, first, we want to detect a glaucomatous disc. We do that through fundus photography. So studies have shown that clinicians only moderately agree on damaged discs. So they did a big survey of ophthalmologists and residents and everybody and looked to see who thought one image was glaucoma and who didn't, and did a poll of that. And there really wasn't a lot of agreement. And that's true. If you ask a colleague, sometimes we don't agree on that. So AI steps in, it takes all of the really subjective processing out of that and allows us to really dive into what the image shows. This is a schematic kind of showing how that works. So the input is the picture, this the fundus photo. The AI is able to use red, green, and blue filters to figure out the edges of the disc, the nerve layer as far as your rim tissue and things of that nature. And then it puts it through multiple layers. So we talked about the layer of the visual cortex. It uses its multiple layers here. And that allows for 3 different processes, which is convolution, pooling, and activation. What that really just means is it puts it through a lot of filters to figure out what is it seeing, where does that fall, glaucoma or not glaucoma, and then it activates the data set that says, yes, this is glaucoma, typically in like zeros and ones, which is very binary computer language, and then it passes it on to the next layer. So it goes through all these multiple layers, it assigns probability of glaucoma being there or not being there. And then once it goes through all of the hidden layers, those percentages or those yeses or nos are converted to percentages. And then it does our back propagation. It looks back to see, was everything weighted correctly? Does this data make sense? Does this prediction make sense? If it doesn't, it adjusts accordingly. If it does, then it's able to say, okay, we have in this example, 90% of our analysis is a yes, 10% is a no. So this is glaucoma. And that's the output of the test. So it's a lot of different layers. It's a lot of way that really our brain works. And it has a lot of checks and balances in there. So it's first the feature learning, the going through those layers, and then classifying it as the result. There's 2 main ways that a fundus photography are being used in AI. The first is cup-to-disc ratio. So basically the AI machines models are shown a bunch of pictures to allow it to figure out what CD ratio is glaucoma and what's not, or what's classifying as glaucoma. There's usually a threshold, typically 0.7 or 0.8. And then when the image of question is shown, then it interprets that CD, says yes or no based on that threshold. And it has a very high reliability. So the AUC score, when we're talking about AI, actually is a comparison of sensitivity and specificity. So the higher the AUC, the better the test. So you can see this has a very high AUC. More interestingly, in my opinion, is that it can actually look at discs and figure out which of those discs are going to be associated with vision loss. So we know that a larger CD is very common in a large nerve. So it doesn't always mean that just because we have a 0.7 or a 0.8 cup, that it's glaucoma. So that means that our CD ratio test is sometimes a little unreliable. However, they figured out that if they send these models enough comparisons of images and say visual field testing, and this visual field testing equals that picture, this vision loss and this visual field equals this disc appearance. It was able to learn that if it saw a certain disc appearance, it probably was correlated with certain vision loss. So now we're able to actually assign glaucoma status based on the consensus of that data with the photos, and really very accurately predict which photos and which nerves are going to be associated with visual field loss. We have applied AI to OCT as well. In the most basic sense, it's been used to analyze RNFL scans. So in the same way that it's analyzing fundus photography by itself, same thing with the RNFL scans, it can say glaucoma or not. But it's also been paired with fundus photos. So like I mentioned, being able to interpret that data on the visual field level can do the same with the RNFL. So we want to be able to predict that through different layers, being able to see the fundus photo, predict the retinal nerve fiber layer, and then is that glaucoma, and then also detect Burke's membrane opening, just like an OCT can do. It can look at the pixels in a picture and actually predict whether we've had loss there on a Brooks level. So a couple of things with regression analysis. We do use it in visual field. We started using that AI in visual fields in 1994. So it can differentiate between glaucoma and pre-parametric glaucoma. Can actually pick up glaucomatous field loss detection over time, and has been found to be way more accurate than clinicians. They, again, compared to residents, attendings, glaucoma experts, and AI beat us out every time. In visual fields, deep learning can predict patterns that clinicians typically overlook. Sometimes we may throw something out thinking it's poor data. AI can pick up on that. It can predict the likelihood of glaucoma hemifield coming back to normal because maybe it really wasn't a progression. It was a rim or a lens rim, defect or not a glaucomatous defect. And they can predict progression with greater accuracy than other methods. So there's been quite a few methods that we've tried to apply to glaucoma prediction over time, and we've learned that we can really do that better. This is just an image here in the last couple minutes of showing where how they classify it. So it puts a percentage, 45% to inferior nasal, 40% to altitudinal, 14.5% to paracentral, and then the clinician can go from there. And this is showing that it actually is able to pick up that progression better than really any of the other models that we've had before. Lastly, AI is used in clinical forecasting. So the Kalman filter has been used across the board. We've used it in the Apollo missions and trajectories of getting to the moon. Now we're using it in medicine. And it actually predicts glaucoma progression 57% earlier than a monitoring system, and can predict personalized IOPs for maximum disease control, which of course is our ultimate goal. So we were able to predict or interpret data much more efficiently and accurately than clinicians, and forecast where we're going. So in summary, artificial intelligence really does a great job of monitoring glaucoma, and then we do have a few limitations. We don't really know how it works, and of course it's only as good as the data in. Earlier stages are a little harder to classify, and comorbidities can kind of throw off the AI model, but that's being, progressed every day. So we want to make sure that it's updated. We give it a big pool. You're not going to see this probably in clinic very soon, but it is coming, I think, down the road. We see it in research right now, and I'm excited to see where it may go from here. Thank you guys so much. I know that's a lot of information, so if anybody has questions, please let me know.
Thank you so much, Dr. Fulmer. That was awesome. I definitely learned a lot from your talk. I was manning some of the chat. There was just one question. I think it was in relation to the virtual reality modalities that you had mentioned. Someone was wondering if you had experience with the micromedical incorporated VR or any information about that.
Yeah, I haven't personally had any experience with micromedical. I have heard of that one. There's a little last data that I've been given on that machine, but to be honest, there's quite a few companies out there that are doing it, and they're all fairly similar. So each of those companies should be able to provide a pretty good data set if you contact them, directly. But yeah, personally, I haven't had experience with that one quite yet.
Yeah, I haven't had any experience with using virtual reality for visual fields, but I'm definitely thinking about it more after your talk. I think there's a lot of patients who could benefit from it, patients who are having difficulty using our, regular modality now, but it was very insightful.
Thank you.
So that
I agree. I'm thinking the same thing in clinic here.
So that will conclude our session for today. I just wanted to put a reminder because I forgot earlier about the raffle code, which is the word cupping. If you will just stay on and hold tight for the next session, which should be coming up shortly. All right. Thank you, everyone. And thank you so much, Dr. Fulmer.
Thank y'all. Have a good day.